Hello, everyone, and thank you very much for joining us today. My name's Deborah Garlick from Henpicked Menopause in the Workplace and author of the book Menopause, The Change for the Better. And I'm delighted to be joined today by Dr. Abbie Laing from my Menopause Centre. And we're going to be focusing on menopause and migraines. And my goodness, this is another popular subject. If I can welcome you, Dr. Abbie Laing, thank you very much for joining us today. We're just going to cover off some of the key themes around menopause and migraines that we've been talking about. And then my wonderful colleague, Sarah, will be joining us at the end for any questions. So please do let us know if you've got any questions during these sessions, and we'll try and answer as many of them as we possibly can. But I'm going to start with one that's kind of a little bit fundamental, Dr. Abbie, because I've never had a migraine. I know I'm one of the lucky ones. But one of the things that was interesting for me when we were talking about this is that, that menopause and migraines can be experienced more during the menopause transition. And I wondered why that was. What could be going on?
It's a really good question, and it's really good that you've highlighted this, because I think a lot of people aren't aware that migraines can actually become more frequent or more severe, or they can be presenting for the first time in the menopause transition. And that's because estrogen and changes in estrogen can trigger a migraine attack. And so any change in estrogen can be a trigger for migraine. So a high level of estrogen, a low level of estrogen, or a declining or fluctuating level of estrogen can trigger a migraine for a person. But sometimes we see this in people when they have menstrual migraine. So in our normal menstrual cycle, our estrogen behaves very much like a wave. And it goes up, peaks in the middle, and it goes down, and then you have a period. For a lot of people, that bit going down before a period can trigger a migraine. So some people have a migraine once a month where estrogen is going down. Some people have a migraine mid-cycle when the estrogen is really high and it's peaking. In the perimenopause, you lose this wave of estrogen, and your estrogen has a really set, well, it has a mind of its own, and it fluctuates like this on a roller coaster ride. So if someone's migraines are triggered by high estrogen, fluctuating estrogen, low estrogen, then this will happen on repeat unpredictably in the perimenopause because of the changes in estrogen that are happening at that time.
Now, that was interesting, because what you were saying is that those individuals that may experience migraines during the menstrual cycle, are these migraines, these changes, or more likely to happen for those that experienced it or maybe had a sensitivity to migraines before?
Yes, is the short answer. So people who are vulnerable or predisposed to hormone-induced migraine, so people who notice they have migraines at set points in their cycle, are more likely to have increased frequency of migraine in the perimenopause, because it's a time when hormones are changing. But sometimes we do see people have their first presentation of migraine. So sometimes we have people all the way up to mid-40s who've never had a migraine and then start getting them for the first time. But definitely that cohort of women who have menstrual migraine or hormone-related migraine can have it more frequently or more severely in the perimenopause.
And for me, when you're saying about the wave, you kind of, if you're living with migraines, then you kind of, if you know you're going to get one, it's a certain point of the month or something like this. But hormones fluctuate so dramatically and quite erratically during perimenopause, don't they?
And that is why this can be a really debilitating condition in the perimenopause. And I've had some ladies who used to have a once monthly migraine. They used to put it in their diary. They knew when it would happen. If their periods are regular, it would be the week before, and they'd be able to prepare for that. But in the perimenopause, where you're having these irregular dips and peaks and troughs of estrogen, actually they can find that they're almost living with a migraine. And I've had some ladies who've had one day a week where they're migraine free, had some people on disciplinaries at work because they can't function with their migraines, they can't go to work with them. but they're having them almost every single day. And migraines they're not just a quick that's over and done with. They last 24 to 72 hours, and they're often preceded by a prodrome, which is a warning and feelings that things are changing, and you can be wiped out afterwards. So if you're getting 1 or 2 migraines a week, and on either side of those migraines you've got symptoms, for most of that week you're struggling with migraine attacks.
And when you say about that you get some sort of warning, what actually defines it as a difference? Because it sounds like it's not just take a paracetamol and let it pass. What does it feel like? How do those symptoms present?
It's a very severe form of headache, really, and it can be very difficult to diagnose migraine. There's a textbook version of it, and then there's real life version, and sometimes the boundaries are blurred. But really, there can be a prodrome, which is almost a warning, a set of warning signs that something is changing. So for some people, that's things like feeling tired, yawning, eye watering, and then a small subset of women. So it's about 25% of women have an aura, and an aura is a set of signs that change. So the most classical aura is where you have zigzags in your vision, or blurry spots in your vision, or feelings like the lights are flashing. But you can have different auras, change in taste, change in function, how you move, how you feel things. And then that aura usually lasts 1 to 2 hours. And then it's followed by the headache. And the classical headache of migraine is that it's on one side of the head, usually behind the eye, and feels like a throbbing, gnawing pain behind the eye. And you just can't do anything when you've got migraine. You have to go and lie in a flat room. Most people like the lights off with minimal stimulation. You can feel very sick. Some people do vomit. And you sort of have to just rest and sleep it off. And then afterwards, for 24 hours, you can have a feeling of being wiped out and not yourself before you recover again. So the classical symptom is a prodrome, perhaps with an aura for some women, and then a headache on one side of the head usually, but not always, with symptoms such as nausea and vomiting and feeling wiped out afterwards. And it is actually considered by the World Health Organization as a disability, because when those attacks happen, you cannot function like you can perhaps with some other types of headaches. Other types of headaches include things like tension headaches, stress headaches, and they're usually much more short-lived. So they don't have auras before them, and usually they feel like a band around the head or a tension around the head, which is quite different to that migrainous headache.
And that's interesting, isn't it? I think because, we all know of things like we were talking about it before, working through a cold is one thing, but working through a migraine, that's not an option then.
Oh no, it because it's a form of disability. People just cannot function when they have a migraine. You do have a spectrum of migraines, so you have migraines that are perhaps milder than other migraines, but in general, people need to lie still, be in a dark room, have no stimulation, and sort of sleep it off. There are different types of migraine. So you've got migraine with aura, migraine without aura. Migraine without aura is the most common type. But then you've also got silent migraine, which means that you get all of those other symptoms, but without the migraine. So you get the prodrome, you get the aura, but you don't ever get the migraine. You get the nausea, vomiting, fatigue. So it's quite a complex condition, but classical migraine is the prodrome, the aura, the unilateral headache, nausea, vomiting, and not being able to function during it.
Not only is that horrible, but it's very, very destructive in life as well.
And some people get neurological symptoms with their migraines. So you have some people who lose function of some of their limbs, for example, which is ever so scary because it can feel like you're having a stroke. But it's not, it's a migraine, it's a subtype of migraine that happens and then it resolves. So they can be very, very frightening for people when they happen.
So I'm going to ask you the question then, what can somebody do if they're experiencing migraines? I mean, presumably if somebody's had them for a long period of time, they kind of know what to do. So it's, what can they do about it? And is it different during the menopause than any other time?
It's not different during the menopause. The frequency of them can increase and the severity of them can increase. From my perspective, the first thing that you sort of think is there a trigger? for this migraine, and there are lots and lots of triggers for migraines, and they range from hormones. Hormone is one trigger that I always look for because it's on my radar, but there's lots of other triggers as well. So things like stress, dehydration, drops in sugar levels, poor sleep, fatigue. These can all be triggers for migraine, even certain foods, so chocolates, cheeses, citrus fruits. So doing a migraine diary is a really powerful tool to, when you get a migraine, to look back retrospectively and say, what did I do that day? What happened that day? But on my radar, I'm always looking at hormones. Could this be related to somebody's estrogen level fluctuating? And something to look for is did somebody get migraines in their menstrual pattern previously? So was it mid-cycle, in which case it's high estrogen? Did they get migraines when they took a pill in the past that contained estrogen? Because that would be high estrogen. Did they get migraines when they were pregnant? Because again, that would be a time of high estrogen. Or have they had migraines related to that week before their period when estrogen is dropping, which would be a declining estrogen? Or perhaps it's the first few days of the period when estrogen is really low, and then it would be low estrogen. And have they had migraines in the past, but they've increased in frequency more recently in the time of the perimenopause? Are there other symptoms that would suggest this is the menopause, such as periods changing, hot flushes, and poor sleep? And then that would point towards it being the menopause transition as a trigger for migraine. So the first thing really is to work out the trigger. What's causing migraine for this person? If I do think it is hormones, then HRT can be considered, and often it's very beneficial, but it has to be the right type of HRT. And what we're looking here is selecting a regime that minimizes hormone fluctuations as much as possible. So it's usually a fluctuation in a hormone that will trigger a migraine. So when, in terms of giving HRT, you've got your estrogen arm and you've got your progesterone arm. People need estrogen to improve symptoms, and progesterone is needed to protect the lining of the womb, because estrogen stimulates the lining of the womb to grow. So anyone who has a womb needs progesterone as well. So you're looking at a regime which gives the most continuous level of hormone at all time. And so you want to start with an estrogen across the skin, so either a patch, a gel, or a spray, because they've been shown to give more stable blood levels compared to swallowing estrogen. So using something across the skin, starting at a very, very low dose, and possibly if somebody sat on the fence about what to use, using a patch is associated with quite stable levels of absorption. So a low dose patch titrated upwards. I should just mention, if somebody has migraine with aura, so that means they get visual changes or warnings that they're about to get their migraine, that individual should not ever be prescribed oral estrogen. So that's estrogen that you swallow. The reason being is that migraine with aura is associated with a very small increased risk of clot formation on its own. And if you swallow estrogen, that too is associated with a small increased risk of clot. So we don't give them together. And that is the reason you might have been told, or an individual might have been told, they have to come off the contraceptive pill if they have migraine. It's the same with HRT. Tablet estrogen is contraindicated if somebody has migraine with aura, but it is absolutely fine and safe to have estrogen across the skin, because that does not increase risk of clot. And by doing that, you're minimizing those fluctuations that are triggering migraine.
I was just about to ask you if there was a difference between the one with aura and without aura. So thank you very much for answering that, even before I asked the question. But it kind of makes me think that some people is there a danger that somebody doesn't know they've got aura? So therefore you would tend to go down the safer route anyway.
Really good question. So I usually start everybody on estrogen across the skin if they've got a history of migraine. It's best practice because it's associated with the most stable blood levels. So yes, normally first line for me is a patch, gel, or spray. And actually, personally, I usually say with headaches, try a patch, because it's lovely stable levels of estrogen, minimizing peaks and troughs. So it is always safer to use estrogen across the skin from that perspective. And if anybody develops migraine with aura when they're on a tablet estrogen, then that should be stopped, and consideration of using estrogen across the skin should be changed to that.
Okay, and that could be patch, gel,
or spray.
Or spray. So whichever one, because I know I've tried different ones, and different people have different responses to them, don't they? So, you know, even if that particular one doesn't work, you've got something else that's transdermal that you can try
absolutely
to sort of balance that as well.
Yes.
So that's really, really helpful, Dr. Abbie. What if, and because I will ask about so that was HRT. Are there other things that could help? Because not everybody wants to take HRT or can take HRT.
Yeah, I'm going to answer that question in just a moment, but I'm just going to go back to HRT because I haven't talked about progesterone, which is the other arm to get right. So we've gone through estrogen, and you're giving back estrogen across the skin to reduce these swings, which are triggering migraine. But you have to take it with a progesterone too, because progesterone stimulates that womb lining. So it's important to think about the progesterone and to use a progesterone that minimizes hormone fluctuations as much as possible as well. So a continuous progesterone, something like body identical progesterone daily, if somebody's able to use it daily, or the Mirena coil, because it's a very low dose of hormone continuously given. And sometimes it's off license, but sometimes I prescribe the mini pill at a dose of 2 a day, because that actually switches off a woman's ovulation. And if you switch off her ovulation, you switched off her background swings in hormones, which can take out migraine. So you have to get both arms right with HRT. And often if you get both arms right, you can get really good control of migraine for women, which is life-changing. If someone's got weekly migraines and they're trying to work and they can't, it is life-changing. For that reason, it's one of my favorite subjects. But yes, some people can't take HRT, and it's really hard to then listen to me say how wonderful HRT is if you've got a hormone-induced migraine. So the first thing I say is look for your triggers. That's really, really important. What is triggering your migraine? If it is things like your menstrual cycle, then you can look at things in your diet. So soya-based things that can actually improve estrogen-like activity, especially if it seems to be once monthly, that can help. But you want to be looking for triggers. So you want to be staying as hydrated as possible. So lots of regular water. You want to be exercising regularly if you can, eating regular healthy meals and avoiding sugar dips, maintaining your weight within a normal BMI range, keeping those stress levels down. Stress levels are a really common trigger for migraine. And actually, when we're stressed, that worsens menopausal symptoms as well. So they work together. Embracing a good sleep hygiene, so you sleep well. Lack of sleep can be a trigger for migraine. Minimizing caffeine, minimizing alcohol. Looking at your diet. And another thing as well is not overusing painkillers. A lot of people don't realize that painkillers can actually cause migraine. So people can get themselves in a bit of a vicious circle where they've got a migraine, so they take painkillers, and actually if you overuse it, that can make migraine worse. So you want to look at how much you're using painkillers, and looking at your diet. So things like cheese, chocolate, citrus fruits, all of these C's, they can trigger migraine. There are non-hormonal medications that can be used to treat and also prevent migraine. So that would be a really good avenue to explore if someone can't take HRT. When you get a migraine, you can have something called a triptan. And a triptan should be taken at the start of the headache, not at the start of an aura. And for a lot of people, that really knocks it on the head and can get good control of it quite quickly. So a triptan medication, which can be prescribed by GPs, is a good option if someone can't take HRT and they've got hormone-induced migraine. If someone has a history of ischemic heart disease, so heart problems, sometimes there's a bit of caution using them, but for most people, they can use them. Other things that can help are high-dose aspirin, paracetamol, and taking an antiemetic to take away the nausea. So having that in your armory, in your toolkit, to treat headache when it comes. If someone's getting recurrent headaches and they've looked at their triggers and they've tried treating it with medications, there are medicines that can be used, non-hormonal medicines, to prevent migraine. And there's lots of different options. So things like beta blockers, candesartan, amitriptyline. These are all medications that can be prescribed by GPs to prevent the onset of a migraine happening. And there's quite good evidence for them. They can be quite effective. And in terms of other things, there are little studies, low quality studies, to suggest things like peppermint oil can help, lavender oil, acupuncture, massage to reduce stress. All of these things can help for some. So you'll see there's lots and lots of options for people.
Yeah, well, I'm glad to hear that, actually, because it sounds an absolutely horrendous condition, particularly if, you know, you've got enough to deal with if menopause hits without increasing your intensity of around menopause, of migraines, increasing your number of migraines that you might get. But also what I was taking from that is actually getting to the root cause of what's causing this, can actually avoid them happening or reduce the occurrence if you're keeping that diary and saying, well, actually, I've got a friend who she doesn't eat chocolate anymore. And she said that was one of the things for her. She gets a migraine. To me, I'm a chocoholic, so to me that would be terrible. But for her, she said, you make the call on it. Yeah. I don't miss the migraines as much as I want the chocolate. If that makes sense. Have I got that the right way round?
It does.
So for her, it made obvious sense that that's what she was going to do. But you kind of have to know to do that, don't you? So there's the option of that. There's the option of looking at from a medical perspective. There's the HRT. There's the other things, and I was particularly taking from that like any time for any of us during the menopause, appreciating that stress can exacerbate symptoms. So look at your stress levels alongside your lifestyle. So that's absolutely amazing.
The perimenopause, which is a time when your estrogen's doing its own thing, it's lost this wave pattern and it's really wobbling and going down. In my experience, that's the time when migraines are at their most florid for women. Migraines seem to be triggered by fluctuations most commonly in hormones. And so it can be nice to know, if you're struggling, that there is usually light at the end of the tunnel. As you go through the perimenopause, your hormones are doing this and they're declining. And then as you enter the menopause, your hormone levels are low and they stay low. So for a lot of people where migraines are triggered by fluctuations, actually after the menopause or in the menopause, migraines usually get a lot better for women.
I was hoping you were going to say that. I was just about to ask that. Is it going to get better? Is there a way, for some people, do they get to the stage where they say, the great thing about being postmenopausal, I don't get migraines anymore?
It usually does. That for the large majority of women, it's these fluctuations. Everybody is different. Some people are high estrogen that trigger it, and so actually it gets better, much better. Most people are the fluctuations that trigger it. So for the large majority of women, symptoms get better. If it's low estrogen that triggers it, which is what's happening in the menopause, they can persist. That's much less common, but it's also quite easily treated by giving a little bit of estrogen to top up for women.
That's wonderful. Thank you very much for giving us some hope on that one. I'm just going to ask my colleague, Sarah, who's been looking at all of the questions as they've been coming in. Hi, Sarah.
Hi, Deborah, and thank you so much, Dr. Abbie. And first of all, there's a huge amount of thank you for your expertise and advice, Dr. Abbie, that you've given so far. Just incredible. And I think as you've been speaking, lots of the questions that people have been asking, hopefully they have been answered. But I just want to go back to a few, because I think there's a few that we can just touch on. Now, you mentioned up front between how, you can go from the headaches into the migraine into another headache. Somebody's asking basic questions. How do you define what's a headache, what's a migraine, and what should you do?
It can be really difficult to diagnose migraine. Sometimes you have to see a specialist to get the formal diagnosis. Classical migraine, typical migraine, which is the majority of women, will have a period of time before the migraine when symptoms change, not always with aura, but sometimes. And then typically the migraine is one side of the head, not both sides of the head, with associated symptoms, nausea, vomiting, photophobia, which means being sensitive to light and also sensitive to sound. That is the classical migraine. Right. So if somebody presents like that, you can be confident and GPs would be able to diagnose that as migraine. But if somebody presents slightly differently to that, it doesn't mean it's not migraine, because you get atypical migraine, and potentially that might need a specialist review to diagnose it.
Yeah, super. And somebody was asking earlier, they've got high cholesterol and they've been told they can't take HRT, they're postmenopausal, and they're getting these visual migraines, and they follow a healthy diet and exercise. So any suggestions for that person?
Yeah, so a high cholesterol is not a contraindication to HRT. And you just have to be cautious which HRT you prescribe. And so actually, obviously, I can't give specifics on your case because I don't know it. But if HRT is started within 10 years of the menopause or beneath the age of 60 years, it's cardiovascularly protective. And it has benefits on our lipid profiles, on our blood pressure, and our vascular endothelium, which is the lining of the blood vessel walls. So that is usually HRT would be fine in that situation. If somebody's outside of that window, it's a more nuanced discussion, but it's not a no. And that just involves a risk benefit discussion with your clinician. If you're not getting anywhere with your clinician, ask for a second opinion. And someone just needs to go through the risks of that. And for the person with recurrent migraine who's got a disabling condition because of it, taking HRT may well be the answer for that person.
Sarah, may I ask another question? Because when you say about referral, we've got somebody else that's had the question. Well, there's two. One that says they've been told by their GP they can't take HRT because of risk of DVT. So it may be that, as you say, ask for a second opinion on that one, or maybe more of somebody that's more expert in that area. And the same for somebody with hormone receptive breast cancer. So I should take those one at a time. For the DVT, take the same sort of advice, that is, go and ask for a second opinion, because everything that you've described about transdermal HRT is lower risk.
Yeah, so transdermal, which means estrogen across the skin, transdermal estrogen, and micronized progesterone, which is your body identical progesterone. The studies that we have on this, which are observational studies, so they're not randomized controlled trials, and which means that they're not the most robust level of studies, they're the one step down. But those studies we have show no increased risk of blood clot above baseline. And so that means that if somebody has a past history of DVT, that type of HRT can be considered for that individual, and it can be life-changing. But it's important the individual might know that they might be at a higher baseline risk because they've had a past DVT, so their population risk might be higher, and also that the level of evidence is not the highest level of studies that can happen. So it's not randomized controlled trials, it's observational data.
Wonderful, thank you. And what about progesterone tablets? Because you mentioned estrogen tablets, but is there a risk with progesterone tablets?
Of blood clots?
For migraines or blood clots?
Right, yes, great question. So there are lots of different progesterone tablets, but body identical progesterone is quite a unique progesterone. And the studies that we have on this demonstrate no increased risk of clot. And again, it's that lower level of evidence that demonstrate it. But that type of progesterone is unique because it appears to be clot neutral. So we use that one a lot. It's one of our favorites. It's also got added benefits in that it can be quite calming for some women, not for everybody, and it can be sedating. So actually that can help migraine as well. It's fine to have that progesterone if you have a history of migraine. Other progesterones, there's lots of different other progesterone tablets. However, they are not clot neutral. So I would steer away from the other progesterones if you have any risk factors for clot or any predisposition towards clot. The only one that I would recommend out of all the progesterone is body identical progesterone.
Thank you. Or a Mirena.
Or a Mirena,
yeah. And someone else is asking, Dr. Abbie, does the Everall Conti contain progesterone, and could this patch work for migraines?
Yes, a really good patch. It does contain progesterone, but it's got a synthetic progestogen in it. So it's not body identical progesterone, but the difference here is that it's given across the skin. So it's a transdermal progesterone, meaning it avoids the liver. And because of that, the studies that we have on it, again, not high level of evidence, but what we do have suggests no increased risk of clot using it. It's a continuous progesterone, which is lovely for migraines, and it's using a patch, which again is lovely for migraines. So it's a good choice. And those patches can be cut in half. So we always say start at a low dose with migraines, titrate very slowly to avoid big swings. And you can use half an Everall Conti to begin with. You can titrate it up slowly until you've got good symptom control.
Wonderful. Do you have any other questions, Sarah?
Real quick one. I'm conscious of time, Deborah, but what is the brand name, Dr. Abbie, for the body identical progesterone?
Utrogestan. So it's body identical progesterone. It's called two things, which confuses people. It's either called micronized progesterone, or it's called utrogestan, which is spelled UTROGESTAN, and that's the same thing.
I've just typed that into the comments box. USTRO.
So UT.
Yeah.
ROGESTAN, utrogestan.
That is exactly what I spelled. Whew, thank you very much. But thank you, Dr. Abbie Laing. This is wonderful feedback and a very interesting subject. I think, well, you've certainly opened my eyes around, how debilitating this can be, but also given us the expert top tips on what we can do about it. So really grateful to you. And thank you everyone for joining us today. And thank you very much, Sarah, for looking after everyone's questions in the background. I do hope you found the session helpful, and thank you, Dr. Abbie, and thank you to congratulations to you and your team for achieving outstanding on the CQC.
Oh, that's very kind. Thank you.
That's the Care and Quality Commission. So Top Menopause Centre. Well done. So thank you very much, everyone. And we look forward to seeing you again next time. All the best.
There will be a recording of the session, won't there, Deborah? A few people have asked, but that will be available on our Menopause Hub very shortly.
Absolutely. Thank you very much, everyone, and have a fabulous week.